This is Greg.
And this is Greg 6 months ago. Greg is a 44-year-old tradie, a once fit and healthy man, but after 25 years of smoking, his habit reached 30 cigarettes a day. Unfortunately, his habit was starting to have implications. Greg began to experience an increasing number of coughing episodes as well as uncharacteristic weight loss. Greg tells the doctor his symptoms as well as his smoking history.
Greg's got lung cancer.
Okay, obviously this diagnosis is not yet sound, but Greg is displaying common symptoms of lung cancer, and smoking is a big risk factor. Cancer is a disease caused by an uncontrollable division of abnormal cells, which destroys the body tissue. In Australia, lung cancer is the 4th most prevalent type of cancer. There are 2 main types, small cell, also known as OAT cell, and large cell lung carcinoma. Approximately 90% of small cell lung carcinoma patients are past or present smokers. Unfortunately, most lung cancers do not cause any symptoms until they have metastasized, that is, spread to other parts of the body. Let's see what diagnostic tests we can use to confirm this.
Greg, I'd like you to get a CT scan and also a sputum cytology.
Cool. The CT scan can give information about any lung tumours and can help find enlarged lymph nodes that might contain cancer that are spread from the lung. A sputum cytology is more likely to help find cancers that start in the major airways of the lung, such as small cell cancers.
The sputum sample shows abnormal cells and metaplasia, indicating lung cancer. The CT shows a non-specific hilar mass with mediastinal widening due to lymph node enlargement. To determine what type of lung cancer and the tumour growth rate, we'll perform a needle biopsy. Greg, we're going to shove a needle in your lungs to examine some suspicious looking cells.
Cool.
Greg, I have some difficult news. You have small cell lung carcinoma. I'll refer you to an oncologist, but treatment outcomes?
In the analysis of the needle biopsy sample, a type of cell staining is used to highlight the proliferation rate of cancerous cells. This is useful as the proliferation rate is typically 50 to 70% in small cell lung carcinomas and much lower in other cancers. Using a light microscope, the cells can also be classified as small cell lung carcinoma tumours due to spindle nuclei with finely granulated chromatin, inconspicuous nuclei, scant cytoplasm, presence of nuclear moulding. Before we return to Greg's fate, let's examine the pathophysiology of small cell lung carcinoma with the help of Professor Squire.
Mucous, basal, ciliated, non-ciliated, and neuroendocrine cells line conducting airways. Pulmonary epithelium is responsible for protection, secretion, clearance, and regeneration. The cell of origin in SCLC is the neuroendocrine cell of the bronchus and cells expressing surfactant protein C. Single-cell necrosis or apoptosis is often identified. P53 and RB1 are 2 tumour-suppressing proteins. Their inactivation causes hyperplasia, leading to SCLC. Dysregulation of Notch signaling, which is necessary for gene regulation, leads to SCLC progressing further. Cigarette smoke contains many carcinogens and toxic agents which damage the ciliated lining of the lungs. It affects epithelial permeability and causes desquamation. Cilia damage means mucus and debris cannot be cleared effectively, causing a heavy cough. Onset of symptoms is rapid and is divided into 4 causes as seen below.
Unfortunately for Greg, little could be done for such an aggressive lung cancer and at such a late stage. As the lung is a highly vascularized organ, small cell lung carcinomas often metastasize to other organs. An MRI of Greg's brain tissue highlighted an enlarged pituitary gland, indicating metastasis to the brain. The survival rates for small cell lung carcinoma are less than 7% for longer than 5 years. So there we leave Greg. But may he always serve as a reminder to protect yourself against cancer risk factors and also to take care of yourselves.